Hello friends, welcome back to my channel with the next video and the part 2 of nutrition in ICU. As I said here, we will embark upon the special situations including the pulmonary critical ill patients, the nephrology critical ill patients, the cardiothoracic or the gynecological surgeries, and so on and so forth with one slide on ERAS. So special situation in the form of pulmonary critical ill diseases patient, where we know that all other points as a standard initiation, avoidance of overfeeding, target calories, the protein requirements, the fluid strategies, and the micronutrients remains the same, except the emphasis on moderate carbohydrates and higher fat proportion to lower the respiratory quotient, that is up to about zero point 0.8. If it goes beyond 1, then we will face a problem, especially for the patients who retain the carbon dioxide. And of course, use of omega-3 fatty acids, which acts as more of a antioxidant in these patients. And so this is another important kind of addition to the patients who are suffering from ARDS as well. As I was talking to you about the perioperative and ERAS, which aims to accelerate the recovery through evidence-based perioperative care, and the focus is predominantly on metabolic optimization, early feeding, and minimization of fasting, analgesia, reduce the stress, minimize multi-organ dysfunction syndrome, expedite the recovery, and reduce the complications with decrease in length of stay. It was initially only for limited to colorectal surgery, but now it is validated for GI surgeries, thoracic surgeries, cardiac surgeries, and oncological surgeries as well, as was published recently in British Journal of Surgery 2024 and Annals of Surgery in 2023. As far as indications of nutrition is concerned, we have a pre-existing nutritional deprivation, where if the patient has GI surgery, then of course the surgeon will be a little skeptical, but we need to discuss with the surgeon and kind of ensure a smooth transition from the fasting state to the early enteral feeding stage, where the patient will get benefited and less catabolism and more wound healing will appear. So there was a Cochrane review in 2011 which talks about early EN even in GI surgery, which will have a direct bearing on multi-organ failure and of course mitigating the chances of morbidity and mortality to these patients. As you anticipate the inadequate oral intake, and in a second week where you clearly see that the parenteral nutrition comes in, especially for the patients who are underlying malignancies or ischemic bowel disease, or sometimes even the gastric obstruction or intestinal obstruction. So this was clearly mentioned in Journal of Parenteral Enteral Nutrition in 2016. So these are clear-cut guidelines as far as parenteral nutrition as a choice of nutrition strategy, especially in GI surgeries is concerned. Talking about the cardiothoracic and the gynecological surgeries, is catabolic patient a hypermetabolic and inflammatory state which induces the insulin resistance and the impaired wound healing. The preoperative NRS screening, the systemic global assessment as far as sarcopenia and correction of anemia and hypoalbuminemia is concerned. The protein energy malnutrition, vitamin D supplements, zinc and iron rehabilitation in the initial 4 to 6 weeks preoperatively has an impact on the post-operative recovery. Intraoperatively, minimal invasive surgery with carbohydrate rich 12.5% maltodextron, sugar control of 140 to 180, and the balanced salt solution with normothermia. In a post-operative period, as I said, orals within first 24 hours, proteins of 1.5 to 2 grams per kg per day. You may consider immunonutrition, but not in all cases, and of course 25 to 30 kilocalories per kg. It has been shown that it has a direct impact on clinical outcomes with decrease in mechanical ventilation, decrease in ICU stay and infection and atrial fibrillation rates. So atrial fibrillation, as we know, that it has a significant impact on the morbidity and mortality, especially for the cardiothoracic patients or post-surgical CABG patients. As far as liver diseases are concerned, again, all other things are essentially the same, except that we need to use balanced energy with avoidance of prolonged fasting and preference of middle chain triglyceride rich formula if the fat malabsorption or cholestasis is a concern. What happens in shock? More often than not, we come across a patient who is in septic shock or a cardiogenic shock patient whom we see in ICU, and they lead to the splanchnic vasoconstriction, thereby having the problems in the glycocalyx of the intestine. It will cause the problems to the intestinal villi, and it will of course cause the translocation of bacteria, leading to septic shock with early catabolic response even in trauma patients. What does vasopressors do to the gut? So clearly vasopressors plus inotropes are more deleterious, and as we know that noradrenaline in some doses which are more than 0.3 micrograms or 0.25 micrograms per kg are bad. There was a notion that dopamine in low dose will increase GI perfusion, but as we know, we don't use dopamine nowadays in ICUs for the last about 20 years. And of course, dobutamine in few situations may increase the GI perfusion. But by and large, remember that the vasopressor, combination of a vasopressor and inotrope is not good. As far as cardiogenic shock is concerned, we deal with the patient with fluid overload and impaired GI function, and of course the sodium restriction, which will minimize the fluid retention. And there were papers which talked about early enteral nutrition in patients with cardiogenic or obstructive shock, especially on extracorporeal therapies. And as you could see, that it was clearly shown that these patients who are on extracorporeal therapy may be associated with lower mortality with early enteral nutrition strategies. Talking about the famous Nutriria 3 trial, which compared low versus a standard calorie and the protein feeding in a ventilated patient. It was a randomized control open label multicentric trial, and here they had three groups. So low group with a calorie of just 6 kilocalories per kg and proteins of only 0.2 to 0.4 grams per kg. Standard group received 25 kilocalories per kg and 1 to 1.3 grams per kg. And after 7 days, the patient had about 30 kilocalories per kg and 1.2 to 2 grams per kg of protein in both the groups. What they found that in both the groups, in a low or a standard group, there was no clear-cut difference in the mortality, but definitely the restriction was superior to the standard calorie in terms of fewer complications and a faster recovery. So it was published in Lancet in March 2023, and it was a low open label study. So Nutriria 3 is something which the exam going students should be prepared with, because it can be asked in the exams. As far as the early and the progressive EN is concerned in septic patients, as we know that you start with the trophic feeds in a very small dose of even 20 to 50% of the fraction to open up the enteral route, and this was well established in a paper presented in the clinical nutrition journal, and it was a ISPEN guideline which talked about protein intake, as you could see, of 1.3 to 1.5 grams per kg per day with a good sugar control. And of course, when we start the EN in a patient who was on vasopressors, so low enteral dose of enteral nutrition is to be started, and it has to be held in the patients who are being actively resuscitated or unstable patients. So patients who are unstable with a higher requirements of vasopressors plus inotropes, they are hemodynamically unstable. For these kind of patients, the EN is actually held. Going further, The renal dysfunction patients, again, essentially all the other head remains essentially the same as compared to the pulmonary or the liver dysfunction diseases. Of course, in AKI, which are not on RRT, the protein requirement is 1 to 1.2 grams per kg, and on RRT, the protein intake goes up to about 1.5 to 2 grams per kg per day, because the proteins are lost in dialysis to avoid the protein restriction. As far as the electrolytes management is concerned, we need to be careful about the hyperkalemias or hyperphosphatemias, and we need to monitor these electrolytes quite closely. So, what are the messages what we can take home today is these patients in shock in ICU are catabolic and they are in anabolic phases. We need to have an individualized approach to any patient you encounter in ICU with shock. Undoubtedly EN is beneficial with you know but we need to be careful about the deleterious effects also, and there is always a dynamism. There is a bit of obscure definitions of hemodynamic stability or instability, but by and large vasopressors and inotropes are more deleterious. Noradrenaline in the dose of less than 0.3 micrograms per kg per minute is okay, where you can start some feeding, and the same holds true for vasopressin in the dose of less than 0.023 units per minute. EN should always be preferred. Use your gut or lose it. The first 3 days onwards, you need to have an open enteral route approach with sufficient of target of about 20 to 50%. PN only if the EN is not tolerated. Low dose strategy to start with, and we have conflicting results and controversies. Of course, we need more and more data. So this is it, my friends. I suppose you must have got the gist of how we go about nutrition in ICU to start with, and how we go up with the energy and the proteins, the macronutrients and the micronutrients, and the special situations like renal dysfunction, pulmonary dysfunction, hepatic dysfunction, and of course the patients in shock, which is not very uncommon. So that's all for now. Thank you so much.